Welcome to Obesity, the Big Picture podcast. Today, we're putting the spotlight on real-world evidence. As the healthcare landscape evolves, so too does the way we evaluate the effectiveness of medicines and medical interventions, not just in clinical trials, but in the real world. Real-world evidence is reshaping how decisions are made, how treatments are assessed, and ultimately, how we can drive better outcomes for patients. My name is Ramota Alaran, and I'm the Associate Director of Real-World Evidence here at Ipsos in the UK. I come from an epidemiological background with a strong interest in how real-world evidence and data can be used to shape the healthcare landscape. I am thrilled to have today Madhu Kubra, an independent consultant with over 15 years of experience in the real-world evidence space. He's well-versed in integrated evidence generation planning, as well as conducting real-world evidence and health economic and outcome research studies. He has previously worked as a global director at GSK and Otsuka, and will bring a wealth of knowledge and context on the intersection between real-world evidence, obesity, and GLP-1s. Welcome, Madhu, and thank you for joining us today.
Thank you very much for the invitation. I'm really looking forward to have this discussion with you.
Brilliant. So let's get started. To start off, real-world evidence is being talked about more than ever, but to those who may not really know about this space, can you help us unpack what it actually means and why it's becoming such a critical piece of the puzzle in the healthcare today?
Okay, so real-world evidence is a data of interaction of humans with the system, whether this could be in a routine clinical practice, visits to your GPs, visits to hospitals, visits to specialty care clinics, and where during this interaction, this data is stored into the systems in the hospitals and GPs, which are called as electronic medical records, or even charts for that sense. And that's one part of real-world evidence. The other part would be the data which is generated from patient-reported outcomes. So these are validated tools or surveys, if to put it very simply, to which patients respond to. And then this is used for research and to quantify various things. Lately, there has been increase in use of wearable devices. Example, we have phones, we have apps on the phone, we have Fitbits, we have many such other smart watches and etc. This interaction of ours with these devices captures many things. There is like vitals, sleeping patterns, blood pressure, and many other things. There are devices. These kind of devices which are approved are used for decentralized clinical trials as well. And when these are used in these cases, those also capture constantly, again, by what is defined, it will capture and thus constitutes real world data as well.
And this is obviously Obesity, the Big Picture podcast. So we're going to be talking a lot about obesity, GLP-1s, and chronic conditions. So let's start with the big picture and sort of whittle our way down. Can you tell us a bit about how real-world evidence and real-world data is being used to understand chronic conditions?
Yeah. So there are many examples I can give. I'll quote couple of them to you, basically. So if you look into the use of statins over the many years, and to lower the for heart conditions, basically to lower the triglycerides, the benefit risks ratio of statins when it was launched and now after decades basically has evolved. We have understood how much to use, what patient strata or what patient strata should be using it, and what it would not have so much effect on. Similarly, we have seen for mental health as well, diseases where, in depression, the clinical trials look fantastic, basically, but in real life, 50% of the patients actually discontinue after 3 months, the medication. The reasons might be very varied. It could be because of side effects. It could be because of the, in some markets, out-of-pocket expenses they may have to give, and they just cannot do that, or even access to these medicines or availability of medicines, or their family conditions. We don't know. To understand all of these, I think real-world evidence has gone a long way to help us to understand these. If we look at some other conditions like obesity, basically, obesity is not I would say, is not just clinical. It has research has shown it has a multiple etiology. So socioeconomic factors, behavioral factors, geographical, cultural, age, ethnicity, all these things have a play in obesity. And in a controlled clinical trial, it's not possible to capture all of these in one go, and it requires long-term observations. Hence, this real-world evidence has played a great role in understanding these chronic diseases.
So you've touched on chronic conditions quite broadly, and we've had a bit of a focus on obesity, but how could other chronic conditions such as, cardiovascular issues and obesity, how might they interact, and how might we begin to consider them from a real world evidence, real world data perspective?
Yeah. I think obesity has a very, very close interplay with lots of cardiovascular or cardiometabolic conditions like diabetes, blood pressure, and many other conditions. Obesity actually increases the chances of diabetes by 5 to 10-fold. Basically, it's quite stunning. It kind of ignites the cardiovascular triad, if I can say, of obesity, cardiovascular diseases, and diabetes. And it's a very, I would say, dangerous combination for mortality, for burden on patients, and the burden on the system and the quality of life of these patients, and not just for 1, 2, 3 years, but for long term until the patients live, and the impact it has on the caregivers as well.
Okay, and that's a really interesting way to look at all of these separate chronic conditions. But if we're looking at it through real world evidence lens or real world data lens, what factors should we be considering when we think about that triad that you so beautifully described, which is obesity and cardiovascular and diabetes?
From an intervention perspective, I think if I can say, the effect of anti-obesity medicines, if we look into this aspect for this particular question, I think the comorbidity profile is extremely important. The effect shown by these medications depends also on what comorbidities the patients have. And that's why the efficacy would vary in real world between these, different patient groups. Again, the ethnicity, the socioeconomic, and in some countries, the geographical locations actually would also play into this. So there is quite a lot of interplay, I would say, and real-world evidence actually helps us to understand this and tease out and to develop solutions along with the medications to be able to address these.
I think that point you made on geography and its influence is quite interesting, and it really highlights the importance of having a real-world perspective and a real-world lens when we're thinking about these diseases. So thank you for that. So we've talked about it quite broadly. We've touched on geography, but let's bring it a bit closer to home. So tell us a bit about obesity, real-world evidence, real-world data, and the UK. Where do you see that intersection? How do you see it working?
Yeah, I'll put you some stunning figures. So I was just researching and I saw there were about 1.4 million dosages accessed until June 2025 in the UK. All of these were in private settings.
So dosages
of anti-obesity medications, and about 200,000 via the NHS. So you could see the interest of the population or the people in general into anti-obesity medicine from a needs perspective, and we'll come to that basically. Secondly, UK has a very fantastic, I would say, data landscape, and will it be in primary care, in secondary care, and the interlinkages which are provided. One of the things NHS Digital has taken seriously is to connect these data sets for research purposes. And the new, I would say, Data Saves Lives initiative, or the slogan, which have been, and that has opened up even more access to data for research purposes and linking them together to unveil and uncover, the avenues where new medications or the gaps which needs to be filled.
We understand a bit better now, real-world evidence, real-world data. There is the concept of integrated evidence generation planning. So for the sake of people who don't know what that means, could you sort of talk us through what that means? And then we'll touch a bit on the relationship between that and obesity.
Yep, sure. So integrated evidence planning is, it's a node, I would say, in a very health economic term. And what it means is bringing all the types of evidence in one place. It's bringing stakeholders together, it's bringing evidence, data together, and it's bringing tactics and strategy together. So when we talk about evidence and data, it would combine, it's a place where all clinical real world evidence, patient reported data, patient voice, health economic data, any other literature which supports, everything is brought together to understand what are the gaps that still need to be addressed, which ones have been addressed, which ones have not been addressed and needs more addressing. That's really the first stage of the value of IP. So in pharma companies, IEP has taken a center stage for any asset. When it's in their planning for launch, integrated evidence planning has become crucial. It has also become crucial because of the changes in the payer landscape and how the assessments and the approvals are going to be done. Also, there are many competitors at the same time who are launching in the markets. So this landscape is also evolving and changing over time to keep abreast and to understand what we should expect in next 3, 4, 5 years, which is during the launch period or, pre-launch and post-launch of your drug. Integrated evidence planning is very crucial.
When it comes to chronic conditions like obesity, which are, and you've already said this, are quite complicated, they have numerous social, biological, physiological factors that influence the life cycle of the disease. How important is integrated evidence planning when you're considering an asset that is going to impact a chronic condition like obesity?
Yeah, I think very good question. I think especially in the case of integrated evidence planning, because it has it's factors which are outside of the clinical interaction which are affecting. It's very important to study those, to understand those, to study those, and to build your planning and evidence around those, to develop evidence to demonstrate the value it can bring in different types of patients, in different settings. We discussed about geographical, ethnic, and etc. Integrated evidence plan can actually help you to amplify or to understand the gaps, and then what are the endpoints of value, not just for payers and regulators, but for patients in obesity, and which is very important, especially in obesity, because there's as I already mentioned, there's an interplay between behavior, beliefs, culture, socioeconomic background. IEP can help actually to understand how these factors affect the efficacy or effectiveness, and design firstly the relevant endpoints or patient relevant endpoints and incorporate that into phase 3 designs. This is during the clinical phase. And what are the factors they should design for post-launch studies or post-launch evidence generation? Are there any additional services that industry can provide along with the medication? It could be, as I mentioned earlier, just education via literature, or just providing psychosocial support, and some of these measures can be implemented when IEP is done in a very greater depth. So it has immense value in this.
I want to pull on a thread that you mentioned, which was around the impacts of integrated evidence planning. You mentioned payers, you mentioned regulators, which I think, we're both in the industry, tends to be the main topic of conversation. But you also mentioned patients. And I sort of want to for a moment, I want us to talk about the importance of the patient voice and the patient perspective in integrated evidence generation planning.
Yeah, sure. I think IEP is a right forum to bring all of these together, especially the patient voice. And in diseases like obesity, it generally goes beyond just the validated tools of patient-reported outcomes. It could be surveys. It could be patient-focused ad boards. It could be one-on-one interviews with the patients to really understand the intricacies, the quality of life, and impact of the medications or impact of obesity. Trying to understand how does it affect their life and their family.
You touched on the almost controversial topic of budget. And when it comes to integrated evidence generation planning, one of the key factors that feeds into that budget is the type of data and why we're using the data and how we plan to use that data. Within the real-world evidence, real data space, we have primary data, secondary data. For those who don't know, could you talk us a bit through what that means?
Yep, sure. Primary versus secondary has been a long-standing conundrum in pharma, and anyone who's worked in evidence would know and have encountered this in their careers. So primary data is when there are prospective data collection, where the data collection would still happen via the routine visits of patients into their clinics, whether it's GPs or hospitals, depending on what you're studying and where the point of care is. Secondary data is data which is already collected via the usual interaction of the patients with the system. We earlier discussed about registries or electronic medical records. And the analysis of these secondary data sets is what has have prominence now since last 10 to 15 years because of the availability of the data and the data sets comparatively opening up in last 10 years or so of the data sets to make those available for research purposes. So for big cohort studies, for big, population level studies, and etc., secondary data, which is data which already exists in the system, the analysis of this data is quite valuable. But it comes with its own limitations. And there are several, missing data which is not collected for the purpose of the study. So the planning needs to be very in-depth in what do you want to analyze and what do you want to understand. Missing data or inconsistent data is very, very, very common in all real world, secondary data. And there are statistical techniques and other things which can be used to address these. Ethical approvals, Achilles heel, has been an Achilles heel but I think with these 10, 15 years of constantly database studies being conducted now in these medical records, I think the research fraternity, the controllers of the data have come to have seen the value it is bringing, and they're becoming more and more open for this data to be available for research. When it comes to primary data collection, it is very specific. In today's world, I would go for primary data collection where really very specific data is required, which is not already captured in the system or in the electronic medical records or registries or other places. Along with that, when you want to, along with the clinical data, you want to really understand the context of physician, choosing and why this medication versus the other was kind of chosen for this patient, to understand these things. Thirdly, where patient-reported data is very important to understand. There's examples of pain and some other, diseases where patient PROs are actually also utilized to understand, how the disease has progressed. So I would say these are, some of the aspects of primary versus secondary and drivers which help you to choose where to go. And one of the biggest or two biggest drivers is the time and budget. Prospective trials could be quite time consuming. Ethics approvals, recruitment, patients coming in, data to be collected and updated and etc. It takes long time. But it can give you the data points that may not be available into the secondary data sets. In secondary data sets, depending on which countries we're talking about, in the US, there's ample data available, and the availability of data is much quicker as compared to some of the European markets. It would take a few months. The time and the budgets are much less as compared to primary. So there is a choice to make based on the research question to begin with, and then the budgets and the time you have.
So you touched on the advantages and disadvantages of both primary and secondary data, and I want to talk a bit more about that secondary data element. We touched on missing data in the statistical analysis that you can do to fill that gap. But what work can we do to fill the gap that doesn't exist in secondary, which is the patient voice and the patient perspective? What should we be considering in our study design when we're trying to account for that?
Yeah. I think this is quite challenging, I would say, and it's still a challenge to have patient voice in secondary data sets. Wishfully, I could say that inclusion of some of the patient-reported outcomes, depending on the disease and the indication the patient suffering from, to be as standard into these data sets. But what does it mean at this? Having the burden of collecting this and from the patients would fall on the primary or secondary care, wherever the care takes place, which are already quite burdened and stretched basically. So I would say the secondary data sets and the data from secondary sources can be complemented via patient surveys and patient interviews. I know it might not always be the same population or the same patients for whom you're looking the data for, but I think you can match those, at the baseline, the characteristics of these patients, and draw some insights which could be generally applied across.
When we're considering the patient voice in prospective studies or primary data collection studies, we have a range of methodologies that we can be thinking about. You've touched on some of them. We have the validated PROs, we have the more bespoke survey design, patient diaries, as well as factors such as ethnography or video recording. How do we ensure that the outputs of these different methodologies are well utilized when it comes to that evidence generation piece of things?
Yeah, I think we need to take a step back. It's a good question. We need to take a step back. Utilization for whom and for what is a question. If you ask, if you want to really understand the utility, it has to be those standard measures of PROs, because they are mapped, they are validated, and then you would understand the utility from these instruments. But what would you understand from a survey? What would you understand from a qualitative interview of these patients is a peek into the actual life of these patients, of what are they suffering in the disease? What are the things that we do not understand when we look from the lens of medicine or treatment or the healthcare system? So it really depends on what you want to study about the patients, and then what are the means for it. If you're looking for quality of life, if you're looking to really get into the depth of what the patient suffers through, when they're going through the disease, what are the carers going through when they take care for some of the very disorders where patients are dependent. So it really depends on what do you want to study, and all of these aspects, in my view, have a place. Some may have immediate utility and direct utility. Some of these, like qualitative interviews and etc., would actually helps you to understand the disease in more depth and the impact it has, which can be translated back into research and designing additional solutions around these for the patients.
So we've spoken about different study designs, study types. How do you go about generating reliable evidence for chronic conditions like obesity? Should we be focusing on primary? Should we be focusing on secondary? Should we be doing a bit of both? What should we really be considering?
Yeah, there is no one answer to this, honestly. As I said, it's a very multifactorial disease, and which affects. It really depends on the research question, honestly. And in my view, I think there needs to be a bit of both in understanding the full realm, and to have really connected data. So there needs to be some prospective elements, I would say, for data collection as the patient is going through the journey through the medication. But as I mentioned earlier, that would mean more time and more budget. And if there are aspects of these which needs to be understood, then that is the way to go. Retrospective, definitely, but it will help you to vary capture huge population in short amount of time and resources, and help you understand the things I've earlier alluded to. The patient voice, extremely important, and I think there are ways, as I earlier mentioned, of when and what type of patient voice would be valuable. So I think there's a mix of these, but it really depends on what is required to be studied.
Now, I would be remiss for us to have this conversation. We don't talk about AI and technology. It's the hot topic everywhere. And a lot of people might not know that a lot of the data that AI is being trained on from a healthcare perspective is that real world data that you touched on: electronic health records, medical records, registries. Broadly speaking, what does it mean for AI, for it to be trained on our real-world data, real-world evidence, and what does that look like when it comes to influencing the healthcare landscape?
Yeah, it's a very hot topic, as you know. AI has had its time from last 2 years. So AI has many, I would say, applications in real-world evidence, and the obvious one everyone would like to jump into is the analytics, basically. And I'll come back to this basically, but what I feel is the AI can do a great job at point of care, where this data is constantly collected, by dashboarding to understand on a unit, on a hospital level, on a GP level, what are to understand the visits, the number of visits patients are having, what is the burden on the system, is the data being collected, what needs to be collected, what is the quantity and the quality of this data which is being collected, and help to understand, what things are missing from being collected. So some of these aspects, I think, are not necessarily thought through, but I feel they should be very much implemented now, because this would give a very great audit of the services which are being at point of care, what is being provided to patients. The second application of is the analytics of the real world data. What AI has already firepowered real world evidence is to understand the hidden algorithms, the prognostic factors. Very, very relevant for in chronic diseases. Basically, what are the prognostic factors, whether it's the genetics, when things are running in family, has the person, if the weight and etc. are captured, are they diabetic, are they having any other cardiovascular comorbidity. All of this AI can detect very, very quickly, has been detecting and can detect very quickly, and can help you to either put prevention plans in place, or help you to understand in depth or how to identify these patients quite earlier, or these are the probable populations in which you can be treating before they start getting into the next stage of the disease. So I think these are the two very important applications of the AI.
I want to project us a bit into the future, but not too far ahead. Wearable technology, digital technology, but also synthetic data. So where do you see where we currently are with wearable tech and what that means for real world data? And potentially how can that be used in the long term for rare diseases where the data doesn't exist? And how can that feed into the utilization of synthetic data?
The wearable technology has come a long way in helping us to understand the data, and especially the real world evidence. It has enabled us to conduct decentralized trials and successful decentralized trials, remote monitoring of patients, whether they're cardiovascular, elderly patients, children with special needs. All of these have been able to be addressed using wearable technology. So it can do more, but there needs to be a more technological advances to be able to capture the parameters of health which are required to address that particular disease. Your second question was about synthetic data. Synthetic data is very great. It mimics the original data. It helps in protecting the identity of the patients. So the data doesn't need to leave the premises of this. It can give you a very great insight into without the restrictions in terms of getting access to the data, going through the ethics and etc. But if synthetic data can help you to understand things very quickly in terms of what are the gaps, what is the effects of interventions, but most importantly, it can help you to project and model out in the future, which is what is required most of the times. But it comes with its limitations. When the whole reason why real world is called real world is because it doesn't have a plan and it doesn't go by the plan, basically. And that's exactly what we would be missing in the synthetic data. Although it can help in modeling out and future predictions, but it needs to be, it has its use cases and it cannot be used everywhere, in my view.
We've been talking a lot about pharma and industry, and I think as we work in industry, we feel as though we're often bound to working in industry. However, academia and public research institutions are doing some really compelling work. So can you talk to us a bit about the impact of collaborations between these sort of different research bases and what that can mean for generating real-world evidence?
Sure. I would start with an example of what we have seen in COVID. What some of our universities and research institutions did, and what pharma could do once that research, collaborating with these in implementing the interventions during COVID. So, the symbiotic relationship actually needs to continue and to be nurtured more, where industry can provide the experience and the power of implementation on a global scale. Can provide the funding and can provide understanding of the disease from a commercial world or the industry perspective, while academia can provide the technical know-how, the expertise. It can provide trust in patients and from, I would say, governments. And most importantly, what it could provide is the innovation in terms of new technologies or new ways of analyzing, collecting data, or ways of interpreting data. So I think there is a long way to go here, and collaborative research is evolving, and I think industry should take a lead in ensuring that they can have these collaborations with research institutions. We have seen many drug discoveries happening through these collaborations, and I already gave you the examples of COVID, which is quite recent, and we have seen the power of combination of industry along with the academia.
So you use COVID as an example of excellent cross collaboration across industry, academia, public research bodies. But what impact could efficient cross collaboration look like for chronic diseases like obesity?
Yeah, I think it will have a huge impact on this. As I mentioned, academia can bring in that trust and innovation. At the same time, it can also bring in novel ways of capturing evidence. As we discussed earlier, the multifaceted aspect of obesity, the academic world can provide this expertise in capturing all sorts of real world data, not just electronic or medical, but also patient voice in an innovative way, and help to generate insights linked to the medical efficacy or effectiveness. And that's where I see immense value in obesity for these cross collaborations.
Let's look ahead. What's next when it comes to real-world evidence, real-world data, and obesity?
What I see is several new GLP launches in coming next 5 to 10 years. What does this mean? And they're not going to be just for obesity. These interventions will branch out in several varied indications. What does this mean for real-world data is it will become essential to understand the impact of the medications on the patients and to understand how the comorbidity profile is changing or affecting these interventions and the impact of these interventions. So that is going to become very crucial, and it will have a huge boom, probably getting its position, of the prime position it should have, which I hope will come in next few years.
For those in the industry, what's one thing they can be doing differently when it comes to real-world data and evidence generation?
I would say inclusion of patient voice, whether it's PROs, whether it's qualitative interviews, or whether it's surveys or patient diaries. As an industry, I would say, more and more inclusion of patient voice, especially in obesity, would be very valuable.
We've spoken a lot today about all things real-world evidence, real-world data, GLP-1s, obesity. This conversation could go on forever. But if you had one message for policymakers and healthcare leaders when it comes to obesity and real-world evidence, what would it be?
I would say the one message I would give is to move from data analysis, data insight to data action. And what it means, especially in obesity, is to provide that extra social care, the psychological support, and more resources to tackle this epidemic.
That's all for today's episode of Obesity, the Big Picture podcast. A big thank you to our guest, Madhu Kubra, for sharing his insights. Stay tuned for our next episode, where we'll continue exploring the key issues shaping the obesity landscape. Until next time, take care.